Welcome to Going Online. My name is Ben Evislage. I'm a technical advisor for online HIV services at FHI 360 and manage the Going Online portfolio. And today we'll be discussing how to go online to accelerate the impact of HIV programs. And the main contents in this presentation will cover a background, why to go online, a framework including various approaches for leveraging online and virtual channels to support HIV service delivery. We'll go over some results and country experiences and then share some resources with you that detail more about these approaches and the results. So why go online? Well, one, online applications and virtual platforms can allow HIV programs to broaden their outreach to previously unreached audiences. Many outreach channels that are using in-person communication or hotspot-based outreach are missing those individuals who are connecting with their peers, sexual partners online, and those new channels, those virtual channels, can be a way to connect with them. You can improve your targeting by using virtual channels, and the reason why is that many individuals who have not been engaged in in-person or hotspot-based outreach don't have that routine engagement in HIV testing, so they haven't tested for a while or maybe never. So going online can help you reach those who have not been engaged in testing, and you can increase your HIV case finding as a result. Additionally, you can also leverage the built-in targeting tools within dating applications or social media to be able to bring your communications to those who are at highest risk as well, such as those engaging in drug use or chemsex or other niche communities that can be targeted with those platforms. Virtual and online channels also offer new options to beneficiaries and to new clients, to your target audiences, to be able to engage in services, options for them to be able to find services on their own, on their smartphone, request services on their own, make their own referrals, and those are examples of self-care, and it puts the power in the hands of the clients to be able to make those service connections. Also, because you are using virtual channels, it helps mitigate the impact of COVID, such as lockdowns or physical distancing, and virtual channels can allow you to maintain that contact with clients virtually and support their service access remotely. So I wanted to take a moment to review various ways that you can reach clients through in-person and virtual channels. You see here, this is our FHI's figure for generations of outreach to key populations. You have the first generation of outreach on the bottom, Outreach 1.0, which is a peer worker going into the community and reaching members that they are connected to, either through their social network or through hotspots. And then the next generation is using that similar approach as the outreach worker, but going to their social network. So opening up Facebook, WhatsApp, maybe a dating application, and reaching members of the target audience through those channels, again, mainly through one-on-one interactions. The third generation is being able to leverage online marketing platforms, such as also Facebook, Instagram, and dating applications, ads that can go out to a large number of members of the target audience at the same time. So this is more broad marketing approaches. You can also include here ads on search engines like Google. And what that allows you to do is when members of your target audience are searching on Google for services or information when they need it, if you have ads there, it allows that member of the target audience to see your services right when they're searching for it. Additionally is social media influencer outreach. It means that people who are already members of the community or who are online and have a large following and have already developed trust among their network of followers, they can be engaged to do promotions or improve their messaging around HIV services and help link people in to those services through their social media posts and stories, etc. And here I just wanted to reflect on the countries that we have listed here as a sample in Africa and their connectivity. So you see here above each country are 3 bars. The top bar is the mobile connections per population. So the number of mobile connections, number of mobile numbers per population in the country. And as you see in many of these countries, and among this network, the CQUIN KP network members, many of them are at or above, even above 100%. That doesn't mean that everyone has a mobile phone, but sometimes there's 2 mobile phone connections per person, and you see that the connectivity is quite high. The second is a lighter blue bar, and that is internet usage per population. So this is internet penetration, and these numbers hover between around 15 to 50%, even higher than 50% in South Africa. And the last bar is social media use, because social media can be accessed easier nowadays. Sometimes the difference between internet penetration and social media is quite small. But you can see here there's a wide range in connectivity by country, but every country does have a good base of mobile phone use and could be a great way to connect with clients virtually, at least by phone call. And for certain target audiences, not all target audiences, they can be connected with through social media across these various countries. So next I want to go over a framework for virtual interventions, virtual HIV interventions, and this is the approach that we've used at FHI 360 and supported several other organizations to adapt and implement. So you can see here, this is the range of HIV services, the HIV services cascade, beginning with identify, reach, test, and on the second part, we have those who test HIV positive going into ART and viral suppression, and those who test negative being linked to combination prevention, including PrEP, and retention on PrEP and remaining negative. So what we've done with this figure is we've condensed those bars at the top, and you can now see below them the virtual and online approaches that can be used to support achievement across those areas of the cascade. On the far left-hand side, you can see approaches used to help identify your target audiences online, learn about those target audiences, which may be unique from your audiences who you reached in person, and engage those audiences in your program. So you have quick online surveys among your target audience, social media mapping to know where exactly on social media you can reach your target audience, such as Facebook pages or groups or in other networks. There's density mapping, which can be used in highly urban areas where there's a lot of users of MSM or transgender dating apps. You can see the pockets of density of those users. You can also employ community advisory groups where you can engage those new sub-audiences who you could reach online into these advisory groups to help you develop your online campaign and your online service delivery modality. There's other approaches you can use to estimate the potential size of your online audience, such as through the ad manager of Facebook or Google. It will estimate how many people you could reach with ads targeted towards your target audiences. And then there's also approaches to help you segment your audiences appropriately, one by what characterizes them in their online profile or persona so that you're able to actually target them appropriately, by what criteria, and also what are their motivations, what are their aspirations, and that is going to allow you to better actually develop the right creative content to bring them into your services. The next stage you see here is reach, and we have categorized 2 approaches under the broad marketing, which I mentioned before, which would be that 3rd generation of marketing, of outreach. Social profile outreach is what we call online advertising, targeted ads to members of your audience. That can be on social media, dating apps, Google ads or search ads, etc. You also have social influencer outreach, which I mentioned before, engaging popular people online who have a large number of followers. Well, they can be large or small, and macro influencers to nano influencers, and they can be engaged to promote HIV services and link people to your service sites. And then lastly, here is a more one-on-one approach that is led by the HIV program or its partners to interact with members of the target audience online, help them understand their service needs, and help them actually access HIV services and document that process. So that would be social network outreach. Often this is also called online HIV outreach or community outreach online, virtual outreach. And then the next step here is how you bring individuals from online into HIV testing or into your program. So we use a software called the Online Reservation and Case Management App, or AURA for short. You see it on the bottom of this figure. And AURA allows members of the target audience who are online to click a link, go to the website, which is where AURA is hosted. They can book an appointment for services at clinics registered on that system. And those appointments can be assigned to the outreach staff who helped them book, and also assigned to the clinics where they booked, so that those service providers can report that the client arrived, that services are provided. And it can also allow clients to refer themselves, because they can use it themselves if they have a smartphone. That's called like self-reach. They can also use it to book appointments for HIV self-testing kits, to order home-delivered services, and also providers can use it to be able to receive requests and then decentralize the distribution of those services to third parties, such as a pharmacy or a delivery agent, such as Uber, etc. And they can coordinate with those second parties on the system and the client to communicate to the client how they will be accessing those services. And on this AURA system, you can load any type of clinic you want, as long as that clinic's management is aware of the system and has identified for the staff at that facility that they should log in and view requests and report service delivered. So that can include government facilities, private providers, community facilities, drop-in centers, mobile health services, and also to coordinate requests for home delivery. Another set of approaches that would help retain clients in care, whether that be in combination prevention or retaining a client on ART, is this virtual case management and cohort tracking set of approaches. And these are very well facilitated on AURA as well. You can assign clients to a cohort of taking PrEP or ART. You can monitor their pill counts and help, as a case manager, you can monitor their pill counts. And you can use that to be able to book new appointments for them in the future so that they can maintain service access over time. You can schedule appointments for virtual consultations, either with a provider or a case manager, and that can be facilitated through a WhatsApp call, for instance. You can manage viral load tracking and referrals through AURA as well. And AURA allows for online partner notification. So clients who are been enrolled in the system can go in and put in phone numbers of partners they want to refer for services, maybe their sexual partners or friends or even children. And then the system will reserve a temporary incomplete appointment on the system, assign it to the case manager to call that individual and help complete their appointment, help them get in for services. And it's anonymous from the person who made the referral to the clients who are being referred. And also in the system, you have automated reminders sent to clients for their appointments and for follow-up. And also another item here is that every appointment booked has a mechanism for the client to provide feedback on the appointment, on the service access. And that's called Link. We call that approach Link. And it can be integrated into AURA, or it can be integrated actually right into your service sites using a tablet and an online survey that you can offer to clients as they complete their service. And in addition to the actual approaches themselves, we've documented some of the indicators that we have used to be able to track the interventions and the results of the interventions across this cascade. So you see here, each set of indicators are color-coded to match the type of platform that would be used to capture that data. So in yellow would be, your online marketing approaches, and you're going to be able to track on those marketing platforms themselves like Facebook or Google Ad Manager, your number of viewers of your content and the number of interactions on that content and the engagement rate. Those are some key metrics that you would probably be reviewing there. And then for individual client support, you may use additional tools, such as an Excel tracker to track each chat that the program has with a client and the resolution to the client's query or any services provided to that client. You could also use a private sector application for online client support, such as Zendesk or another, to be able to track that individual client support. And then you see the indicators in red, which are those that are actually captured within Aura. So you have number of people landing on the site viewers. And then you have these 4 custom indicators, which we've developed for number of risk assessments completed on the system, number of appointments booked on the system, number of appointments that have been booked and reported as arrived by the provider, which is on arrive, and then also finally, number of services provided to clients who had booked and arrived. So that's just simply disaggregating those appointments by those who have been provided HIV testing versus PrEP versus ART. And those red items can be captured on Aura. The other list of indicators here in blue are standard PEPFAR program indicators for service delivery that are typically captured in a larger program-wide data collection tool, and we use DHIS2 typically as a standard for collecting that kind of information from the clinic level. But additionally, these same kinds of indicators can be collected within Aura. So programs can decide if they'll be reporting this information into Aura in addition to reporting into DHIS2 if they want to have the online clients tracked separately. Or in some situations, you may have a unique network of service providers, maybe a private sector network of service providers that would use Aura for reporting HIV testing and other services because they may not have the tools or capacity to use a DHIS2 system, and Aura may be easier. So then you can keep your data entry on 2 different systems, DHIS2 for your overall program, Aura for the online clients, or Aura for your private sector providers only, and then you aggregate together and you report to whomever, your donor, or etc. And lastly is this online client feedback survey. We've used SurveyMonkey to collect this information in the past. However, Aura is also now going to be including a survey right in the system. So when clients book online, they can be redirected back to Aura to complete the survey, and they won't need to be directed to SurveyMonkey. But there's a variety of online survey tools that you could use to facilitate that. And I just want to take a minute to review the reach of these virtual interventions that we have been supporting HIV programs to use, including in the Caribbean, Africa, Central Asia, and Southeast Asia. You see those countries in blue that are using an Aura-based application. There's around 27 countries. And those in light blue that are just rolling out their Aura application. And those countries in yellow that have started with technical assistance to plan their virtual interventions but have not yet used an Aura application. So a little bit about Aura. I want to go into a little bit more depth here about this particular solution. Aura is a web app, so it's not downloaded onto a phone. It's simply available online. And it was developed by FHI 360 in 2017 in Thailand originally, and now is used in 27 countries. There's a global deployment that is already available for countries to log in and use, and there's also country-specific deployments that can be used for a particular country only, and I'll get a little bit more into that. It includes a client-facing interface for clients to use for accessing services, and a provider or staff-facing interfaces as well to view service requests and to manage appointments and to analyze data. And you can see here on the right-hand side, the Aura platform used in Vietnam, which has been used to support also private sector collaborations in other countries, in India, Kenya, and Jamaica. So a little bit more about the two ways you can deploy this application. Historically, it's been used to copy the main software, put onto a new server, make it available through a new domain or a new website, and then the country program would adapt the functions, add their specific languages, and add their clinic services and users. And which is a great way to be able to host this application in country for long-term sustained use. Another way that this has been deployed is a global application, and we have deployed this on the domain called quickres.org. And this version allows multiple countries to use it at the same time. It means the backend access is segmented by country. So if I log in from Kenya, I cannot access any information about Botswana. Also for clients, if they're going to the site from their country, they're immediately going to be shown that the version of the site for their country, including in their language and viewing clinics and services that are offered in their country. The benefit of using QuickRes is that it's already available. You may only need to add your country's users, maybe add a language that can be shown to users in your country, and you can start using. You don't need to buy any new server space. You don't need to buy any new materials for that. So what many countries do is they start by loading their clinics and users onto QuickRes, they pilot, and maybe they continue on that system. Or they can then copy QuickRes, delete all the other countries' information, and continue only with their own country on their own copied version. And then they can continue to use the system, but hosted on their own server and on their own domain. And then they can begin to add new functions and change the branding to match their style. So just to review some of the client-facing functions on Aura, clients can do an HIV/STI risk assessment. They can book appointments for services, including home delivery and virtual consultations. There is a client referral tool, so a client can be able to refer their partners for services anonymously. There's live chat support, so for instance, through Facebook Messenger or through WhatsApp, clients can request support while on the Aura application. There's a COVID-19 self-screening, so before a client actually books an appointment at a physical clinic, there's 3 questions to understand COVID risk and potential exposure. And if there is a risk, it limits them from being able to book at that physical clinic, but they can book home delivery or a virtual consultation or chat. There's also SMS reminders that are sent to clients who do book an appointment. And there's a video here that you can click to view to see the client-facing functions. It's an explainer video that can be sent to clients directly on how to use Aura. For some of the program and provider-facing functions, there is a clinic appointment management interface. So a clinic worker logs in, they see only the appointments assigned or booked at their clinic, and they can immediately report which appointments have arrived and services provided to those clients. And there's a reporting interface that is attached to each appointment so that providers can report arrival, HIV testing, self-testing, STI testing and treatment, ART, PrEP, family planning, violence screening, a couple of others. There's also, within all the testing services, there's a decentralized service referral option so that if a client books for testing, the provider can refer that client to receive the testing from another provider in the system, such as a private lab. And you can also use this decentralized service referral for ART and PrEP, meaning a client can book for those services at their main clinic or provider, and then they can decentralize or authorize a third party to distribute that to the client. Each of the records in the system are assigned to a specific outreach worker or case manager. So there's an outreach worker view of appointments and a case manager view of appointments. And the permissions of what they should be able to see on each appointment can be set for each worker. There's also a longitudinal view of clients in an ART and PrEP cohort. So you can select, I want to view my PrEP cohort. It'll line list uniquely all the clients that have initiated PrEP. And at the far end, it'll also show their live pill counts based on their most recent refill on the system. So our case managers can use this to be able to assess which clients need to be supported the soonest to have their next booking made. And the system uses codes in the link where you access the site to track the results of promotions. So you create your codes on the back end, you assign each code to a certain marketing purpose, such as ads on Grindr or ads on Facebook or influencer promotions. You use that code in the link to promote the services. And what happens is when clients click that link that contains that code, it goes to QuickRes or goes to Aura, and Aura will capture that code in the reservation record automatically. So this allows HV programs to track results very granularly of their online outreach and marketing approaches. It also includes live data visualizations on the back end. There's a cascade view from appointments, arrivals, HIV tests, ART initiation, PrEP initiation, and viral load. And you also have a timeline view, so you can see monthly your volume of appointments and arrivals each month. And you can do a comparison view. You can compare between various outreach modalities or various clinics the results of bookings, arrivals, HIV tests. And lastly, there's a index testing cascade, which is viewing the results of client referrals, successful arrivals from those referrals, and testing results from those referrals as well. Backend users can also use the SMS blast function to be able to select a cohort of clients within their country, maybe clients who are on ART or clients who had booked for family planning or all MSM clients. You can program a message to go specifically to those cohorts and send a blast to all of those at the same time using Aura. And programs can decide which SMS notifications they would like to send to clients. Many are already automated, but some can be turned on, and we can add new ones based on the requirements. And there's a link here that describes the provider-facing functions of Aura. It's using an older version of Aura, so there's some additional functions that aren't described in the video, but it gives a pretty good review. And you can try this yourself. You can go to quickres.org/100, and /100 just brings you to the testing environment for QuickRes, because this is a system that's really being used in many countries. So avoid booking an appointment in a real country, because the clinics will see that. So you can go to quickres.org/100, you can do a risk assessment, and you can book a fake appointment there. I want to take a minute to give some results on some of these approaches, particularly online outreach and virtual case management, and share some experience from several country contexts. This is just giving you a snapshot of results of bookings, arrivals, and risk assessments on Aura platforms. You can see the country-specific deployments on the left-hand side in Asia and the right-hand side in Africa. And in the center, you can see QuickRes specifically. And the results on the left-hand side and the right-hand side are for the month of March for those platforms. And in the center, you're actually getting a screenshot from QuickRes among the 8 or so countries that use QuickRes. You're getting all those results combined for each month. So you can see here in March, 1,217 appointments were booked on the system across these 8 countries. And 805 appointments arrived. So this just gives you a snapshot. What this shows is that many countries are using this system to be able to reach a new niche segment, maybe a small segment in their country, who are online. In other countries, it's used for a broader segment of clients. Maybe all clients on ART are supported on this system, but in most countries, it's a more niche approach, and that's why some of the numbers look a little bit lower. In terms of results, in Thailand, they have been doing online HIV outreach for a long time, using all sorts of approaches, from social network, social profile, and influencer approaches. And in the country, nearly 79% of the population uses social media. Very high percent of people are online already. And so what they found is that as they did online outreach, 69% of the clients who they reached online were new to their HIV program, which means that their online outreach efforts were bringing people in who probably would not have been reached if they only did in-person, hotspot-based outreach. And they also found that online outreach contributed 10.3% of overall program reach, and 10.7% of all testing was a result of those they reached online. And then finally, 15.3% of all positives diagnosed by the project were reached from online. And this is because the case finding rate for those who are reached online has been higher than the case finding rate for those who have been reached offline. But something to note here is that 79% of people in Thailand are online, are on social media, but only 10.3% of the project reach is from online. So they do have actual scale to increase the number of clients who they are reaching online, given the internet usage in the country. In Nepal, it's a little bit different of a situation. They started implementing around the same time. They use primarily social network outreach, which is an approach like online outreach workers, to be able to reach members of their target audience, mostly one-on-one approaches. And also in the country, they have a little bit less social media use, around 44% nationally use social media. And what they were able to find is that among the clients who they're reaching online, 90% of those are new to the program. And 81% of those who had been booking their appointments on Aura said that they currently did not know their HIV status. So this just shows that there's a demand and need for online HIV outreach and referrals or testing among this online audience. What they also found is that online outreach was contributing 9.4% of their overall program reach, 3.9% of testing, and this could be a result of when reaching clients online, it's sometimes hard to actually bring them into the clinic than if you had met them in person. So the testing numbers are a lower proportion than compared to the proportion of reach. And then lastly, 11% of the overall program's case finding was a result of online outreach. And again, this is because those who they are testing from online are resulting in much higher case finding, at higher risk, or haven't been engaged in testing as frequently as those who have been engaged in testing from in-person outreach. And in Mali, this is the last example that's quite different. They launched Aura in 2020, right during the middle of COVID lockdown. And the country has around 10% social media use, so quite low. And so they're using this really among a niche network of key population members who are online. It's not meant to service all beneficiaries. And among the clients who they were reaching online, a high percent, 80%, were new to the program, not reached by the in-person or hotspot-based approaches. And 47% of those who have been reached and booked an appointment online reported that they've never been tested in their life for HIV. So these are really new individuals. In terms of contribution to program results, you can see it's lower than Thailand and Nepal. 2.6% of overall program reach was from online. 1.4% of testing the project was from online, and 2% of overall program case finding was from online. But this is just to note that this is a small team of 3 online outreach workers based centrally in Bamako that do this outreach. And so this represents actually a scaled approach in that context, that it is specifically for MSM program for those who are online in a context where just 10% nationally use social media. So in this situation, they could scale up a bit, but it's reaching scale given that niche of programming. And I wanted to also review virtual case management, how it's been implemented and what were the results. What we found in Nepal and Indonesia during COVID-19, the limited ability to meet with clients face-to-face necessitated the transition to using online and virtual platforms to support their retention on ART. So in Nepal and Indonesia, they shifted very quickly in the month of March 2020 to using virtual platforms to stay connected with their cohorts of clients on ART. So they transitioned within a month. They used existing monitoring tools and adapted them to capture online engagement with their beneficiaries. They also deployed home-delivered ART mechanisms, so clients could continue accessing ART through home delivery by Uber or a similar rideshare app, for instance, and this was in Jakarta, or in Nepal, the Ministry of Health authorized that members of the PLHIV network would be able to go out of their houses and help deliver ART to community members, to PLHIV during the lockdown. And the costs were quite low. We found that the additional cost to go online and provide the virtual support was around $2 to $8 per PLHIV per month of that support. And during this time, very critically, the clinical outcomes for clients in the ART cohort of both programs stayed the same. So that means that the percent of clients on ART that were interrupted in treatment was the same before COVID and before virtual case management, and after COVID and after the introduction of virtual case management. Viral suppression also stayed the same in both countries before and after, and that's the percent of clients who were virally suppressed. Viral load coverage actually increased during this time as there were other approaches to support viral load coverage, viral load testing rollout during this period, particularly in Nepal. Lastly, I just want to go over a couple of resources to leave you with for additional guidance and support on some of these virtual interventions. We have a budgeting guide and programming guide for HIV interventions that was published just a few months ago. And this includes all the approaches I mentioned in the introductory remarks, that menu of approaches. It describes each one, and it provides sample budget inputs and costs that programs can consider when planning their approaches. We also have specifically pulled out a guidance on the secure use of mobile devices and apps for staff that provide virtual client support. So this would be useful for your online outreach workers and your virtual case managers. We have a guidance and a tool, a standard tool that can be used for collecting client feedback, electronic client feedback, and that's here in the link technical guide. The online reservation application is documented in a technical guide on QuickRes. That's the global deployment. You can use that as a resource to understand how that software functions and how you could use it in your program. And we have a variety of other technical briefs and some of the approaches that I've mentioned before. You can feel free to view all of our resources at fhi360.org/goingonline. And I can show those here. So you see here, you can contact us by email if you have any questions or requests for assistance, going online at fhi360.org. And then the website actually has all these resources linked to it. So fhi360.org/goingonline. I'd like to thank my team, the Going Online team, and feel free to send us any questions or concerns or topics by email. Thanks.